Hello and welcome to 5 Minute Pharmacology. Today we're going to be talking about morphine sulfate. Morphine sulfate's trade name is Roxanol or MS cotton. Its classification is a narcotic agent and it's carried 4 milligrams in 1 ml and it is carried in 5 vials in our drug box. Just be advised, some other agencies that border us may carry morphine a little bit different. If you're ever in the position where you're drawing up their morphine, it may be seen as 10 milligrams in 1 ml. Just, um, just a thought in case you're pulling up a drug, make sure you're confirming those the way it's packaged from a different drug box other than your own. Some pharmacology and actions of morphine. It is a narcotic analgesic. It alleviates pain by acting on the pain receptors in the brain and it elevates the pain threshold. Remember, it does not eliminate the underlying cause of pain, it just masks the pain itself. It can act as a CNS depressant and it does depress brainstem respiratory centers, increases venous pooling, vasodilates arterioles, and reduces preload and afterload. And it does release histamine. So, some indications is for analgesia or pain. Some contraindications with morphine is respiratory and CNS depression, hypotension, and morphine sulfate allergy. So we want to be careful with giving these drugs, and some precautions and side effects is because morphine releases histamine, you may see a drop in blood pressure after giving this medication, especially in higher doses. So that is why hypotension is a contraindication in giving morphine. We want to be cognizant of that, and we should elect maybe a different drug that does not release histamine, like fentanyl, would be a more appropriate choice in those settings. Also, the respiratory and CNS depression that morphine may cause, it can become worse in patients with underlying disease, like lung disease, or if they're on any other co-ingestions like benzodiazepines or alcohol ingestion or something like that, any other type of CNS depressant. So just kind of be on the lookout for some of those things after giving morphine to patients. Check your vital signs before and after, and also get a good quality pain score before and after each dose. Also, when morphine is given to treat pain, the goal is a reduction in pain, not the total elimination of pain. We can give this morphine IV or IO. Onset is within seconds. Its peak effect is 20 minutes, and its duration is 2 to 4 hours. So we would give it zero point 0.1 milligrams per kilogram to a max of 2 to 5 milligram increments to total 15 milligrams for pain. In the setting of chest pain, so remember, you can give morphine for chest pain when it's unresponsive to nitro. So that's the only time we should really be going down is to give morphine or fentanyl is when chest pain is unresponsive to nitro. And you would give half a dose. So it's 0.05 milligrams per kilogram IVIO, max single dose of 3. The reason why they do this is because in the setting of unstable angina or NSTEMIs or non-STEMIs, um, morphine has shown to be in the cause of a higher risk of mortality compared to those who weren't given morphine. And so just be cautious of this when giving morphine to chest pain patients that are unresponsive to nitro. Okay, maybe elect to a different type of opiate instead. And we can give this for RSI for post intubation at zero point 0.1 milligram per kilogram, IVIO, max single dose of 5 milligrams, and you may repeat it as needed. So just remember, respiratory depression can set in. I have in the notes here at 7 to 10 minutes after administration. So we want to be cautious of that as well. But hopefully you learn a little bit about morphine today, and I appreciate your attention.